Hello, everyone. Welcome to the Osteoarthritis Action Alliance Lunch and Learn for October. My name is Kirsten Ambrose, and I appreciate all of you taking the time to join the presentation today. Before we get started, I wanted to go over a few items so you know how to participate in today's event. You will see a control panel on your screen with a few functions. In the audio pane, please be sure that the correct radio button is selected for telephone or VoIP mic and speaker's headset, depending on how it is that you've dialed in today. That'll reduce feedback. We will have a question and answer period at the end, and by default, all of your lines are muted for the duration of the presentation. I can only unmute one person at a time, so if you want to ask a question, there are two ways that you can do that. First, you may type or text your question in the question pane on your control panel, and I will read it at the end. Or you may raise your hand by pressing the hand raise button, that little hand with an arrow, if you wish to ask a question yourself. Once you press that raise your hand button, I'll be able to unmute your line. And if you have dialed in by telephone, be sure that you have entered the audio pin as displayed in your control panel, that #, so that we can hear your question. That will activate your audio. So with all of that, I am pleased to introduce our presenters from the Hospital for Special Surgery in New York. Sandra Goldsmith is the Director of Public and Patient Education at the Hospital for Special Surgery, where she oversees community benefit and community service programming focused on general wellness and musculoskeletal disease. Sandra earned her master's degrees in nutrition and organizational psychology at New York University and has worked in the field of nutrition and wellness for nearly 20 years, including roles as the Director of Nutrition Services for community pediatric programs at Montefiore Medical Center, as the Administrator for the STAR Center for Preventive Health and Special Initiatives, and as an adjunct professor at New York University and Hunter College, teaching nutrition classes to graduate and undergraduate students. She has extensive experience designing, delivering, and evaluating innovative wellness programs for underserved populations and for those with specific health needs. Next, we have Titi Ologhobo, who earned her bachelor's degree at Babcock University in Nigeria and her master's in public health from Westchester University of Pennsylvania. With her experience implementing large-scale program evaluations, she has collaborated with the New York City Department of Health to measure the impact of a program aimed to reduce teen pregnancy citywide. She has worked with CDC to develop and implement comprehensive regional capacity needs, and she has managed very large data sets in 13 states across the nation. Now at Hospital for Special Surgery, TT oversees the strategic development, design, and implementation of a coordinated approach for measuring the impact of public and patient education programs. This brings us to today's Lunch and Learn, titled Impact of Hospital-Based Exercise Program on Musculoskeletal Health Outcomes in Older Adults. I'm pleased to welcome Sandy Goldsmith and Titi Ologhobo.
Thank you, Kirsten. We're really happy to be here to be able to present our research today. I'm Sandy.
I'm Titi.
And I'll start the presentation and then I'll hand it over to Titi to talk about the methodology and the results. So to get right into it, I'm going to just start with a little bit of a background that really should be familiar to everyone out there. OA is the leading cause of disability in the United States, with an estimated 27 million Americans having this disease, with a cost of $89.1 billion per year. It affects more than 70% of adults between ages 55 and 78. And broadening that, about 25% of people suffer from long-standing musculoskeletal conditions. And the last bullet really talks about physical activity and how it is effective in helping people with OA. So to talk a little bit about who we are as an institution, we're an orthopedic hospital and we're known for our expertise in musculoskeletal and rheumatologic conditions. But more than that, we're also known for our rehabilitation, our expertise in rehab. We're committed to providing quality care and improving mobility, enhancing quality of life of our community, and you'll see that reflected in what we're going to be talking about today. We have a long-standing history of providing community service and programs to populations of all sociodemographic backgrounds. We focus on OA, we focus on osteoporosis, general wellness, lupus, and we really reach people across the life cycle, children, seniors. But today, we're going to be talking about one specific program, which is our Osteoarthritis Wellness Initiative. And the overarching goal here, excuse me, is to educate, raise awareness, and reduce the impact of OA in our community. And there are two main components of this initiative. The first are our educational seminars and workshops. They could be anywhere from an hour to a half day. And we, excuse me, we partner with physicians, with rehab specialists, with nutritionists to present topics on OA and OA nutrition and pain and anything that is related to OA or musculoskeletal disease. Our second component is our exercise classes, and that's really what is going to be the focus of today's presentation. Both of these components, well, actually the educational seminars are free and our exercise classes are low cost, but all of our programs are open to the public. Our participants do not need to be a patient of HSS. So this just gives you an idea of who our team is. I do want to really give recognition to TT, who really analyzes all of our data, Robin Wiesel, Linda Roberts, and Madeline Meisland, who really run these programs. So to narrow down to focus on our research today, that is on our exercise classes. And our goal here is to improve musculoskeletal health among our participants by a few things. First, decreasing pain, stiffness, fatigue, falls, and health limitations. We look to improve health status, level of physical activity, and self-efficacy around exercise. And lastly, we also are looking to improve balance. So to give you an idea of how we do this, how we run our programs, we have our exercise classes and we offer them once per week. And we offer a range of exercise classes from Pilates to Yoga Lattes, which is really a mix of yoga and Pilates. We also have Tai Chi and dance. All of them are led by certified fitness instructors. And our participants are English-speaking older adults. English-speaking older adults.
Well, thank you, Sandy, that was great. So I'm really going to take us from here, moving forward, to talk about, the methodology that we had implemented in evaluating a program. Again, also looking at our results, and we're also going to highlight some of the validated instruments that we have used, and some of the limitations that we had encountered. So really diving into it, we had implemented pre and post methodology and able to, assess changes in health outcomes over time. And really the surveys are, given at the beginning of the class and also at the end, the posts are given at the end of the class. And really this is captured. And then we also capture program satisfaction data, and really these are actually in our post surveys really to understand the impact of this program. And then also they also provide some comments for us to see ways we can improve on a program. Again, I just thought I should note that, our program is actually approved by the HSS IRB, and every year it is always approved. So going straight into our measures. So really in measuring some of our outcome measures, we use standardized and validated instruments. And the reason why we use this specific instrument that I'm going to be going to shortly is because they are best suited for self-reported data. So going into pain, so for pain, which is actually one outcome of interest, we had, 3 different outcomes that we wanted to look at, looking at pain relief, which is just a yes or no response, and then looking at pain intensity, which is measured by the numeric pain intensity scale, and also pain interference on 7 aspects of daily living from the brief pain inventory. So when I say 7 aspects, an example is, for instance, sleep, or mood, or quality of life, relations with other people. So those are some of the aspects that we looked at, but we'll go into that in detail later on. And then we also were interested in looking at level of stiffness, where we had used a single item stiffness rating scale from the brief stiffness inventory. Similarly, looking at level of fatigue, also using the single item fatigue rating scale from the brief fatigue inventory. And again, just to know that most of these scales are on an 11-point scale, where 0 is for the least and 11 for most. Our interest also was to see if balance had improved, so measuring this on a 5-point scale from excellent to poor. And one other outcome of interest was really looking at the level of physical activity. We really wanted to know if their level of activity changed, given that they had participated in this program. And we had used a 3-question physical activity assessment, really looking at light, moderate, and vigorous physical activity. So in doing the analysis of this program, we had done the analysis in 3 different levels. One was really to look at the total sample to see the program impact in the total sample. Secondly, was really to see program impact by class type. So really trying to understand, like, was there a variation depending on the kind of class they attended. And then thirdly was really to also look at impact of programs specifically on participants that indicated they had arthritis conditions, either osteoarthritis or rheumatoid arthritis. Just to note that specifically for this analysis, only matched pairs were involved, meaning only participants that completed both pre- and post-surveys were included in this analysis. And we had used the paired sample t-test, again, to see if there were any changes in outcome seen after the program. And also the chi-square test was also used to see if there was any improvement seen in some of our outcomes. Importantly, demographic data was also collected, age, race, and gender, again, to understand the demographic of a population. So really diving into the results, the results really captures aggregate data from a time frame of spring 2011 to spring 2014. And during this time period, about 803 participants were involved in our program. However, about a quarter of those only collect and responded to pre and post surveys. So again, that is really our sample size for this analysis, because this is really those that had both pre and post surveys. So going into our demographic information, we can see the breakdown on your screen, and looking at majority of a population were female and white. And then also looking at the breakdown of the age, we can see that most of them were generally older. So let's dive straight into the results. Looking really at pain relief, and really this was when participants were asked if they experienced any pain, muscle or joint pain 3 months before participating in the program or after participating in the program. And then we can see that there was a statistically significant decrease. And then looking at pain intensity, when participants were actually asked to rate their level of pain intensity after participating in the program, we could see that there were statistically significant reductions from a 4.6 to a 3.9. So I'm really going to stop here and piggyback on what Sandy said. Really, pain interference, and this indicator is really key, because one of HSS core mission is really to improve mobility and improve physical function. And this indicator is really key because this would help us to know if we're really achieving one of our core missions. So we have looked at pain interference on the aspects of daily living: general activity, mood, walking ability, normal walk, relationship with others, sleep, enjoyment of life. So we really wanted to know, did pain interfere with all these activities listed here? And looking at our results, we can see that there was actually a statistically significant reduction seen across the board on all of this. So again, this definitely tells us that our program is making a great impact. So moving on to looking at level of stiffness and level of fatigue, and we had seen that participants did experience a drop in level of stiffness after participating in the program. And also looking at fatigue, you can see there was also a significant drop in level of fatigue in our total sample. Level balance ratings, it definitely shows that majority of our participants rated their balance positively. So there was definitely balance improvement after participating in the program. And then interest in also looking at the physical activity, level of physical activity, and significant findings were actually seen for participants that were engaged in moderate intensity and vigorous intensity physical activity. Again, this is telling us that our program definitely has a great impact, and also it's helping to improve healthy lifestyle. And again, this is really some results that were exciting to see when I did the analysis. So now let's look into our exercise type. So we're trying now, this result really captures program impact by the classes. And looking again at pain interference on aspects of daily living. So I didn't really highlight all the 7, but I just highlighted 4 where I thought was interesting to note. And then looking specifically at Pilates, we can see that, across all, the 4 general activity, mood, normal work, enjoyment of life, we could see that there were drastic reductions in pain interference. And also looking at the yoga ladders, participants that also were engaged in yoga ladders did experience, significant reductions across the board on 4 of these aspects of daily living. So I thought it was also interesting to note pain relief. Again, not really highlighting all the classes, but specifically looking at Tai Chi and yoga, we can see that, participants did experience pain relief. And however, if we look at dance, there was a reduction, but not at significant level. Again, this could be, attributed to the small sample size there. And looking at a balance rating, looking across the board, we see that participants really rated their balance positively according, because of this program. And we can see that there were actually statistically significant findings found in 4 out of our classes, except in dance, which again could be attributed to a small sample size. So pain intensity, looking at pain intensity, again, I thought it would be nice to capture this results in all the classes, and we can see that there were reductions seen. However, only statistically significant reductions were seen in yoga class in participants that were in the yoga class and in the yoga ladders class. So now, our third analysis was really looking at participants that had arthritis conditions. And as I had mentioned earlier, really specifically osteoarthritis and rheumatoid arthritis. One thing I want to note is you can notice that the sample size, is small. And again, this is really because we had started collecting our data in 2015, which we had identified as a gap. However, we're collecting it now, and we're going to continue to measure that and track that over time. However, given the small sample size, I thought it would be interesting to highlight some interesting themes that we had seen. Looking at pain intensity, there was a drop, however, not at statistically significant levels. Looking at pain interference, it dropped in all aspects of the quality of life, but again, not at statistically significant levels because which could be attributed to the small sample size. But interestingly, we saw that mean fatigue level actually dropped significantly. So again, this was interesting to note. And also one interesting key thing that that jumped at me was if you looked at physical activity, it seems like most participants that had some kind of arthritis condition were actually engaging more in vigorous physical activity because there was a significant increase after participating in the program. So as earlier mentioned, program satisfaction data was really collected to understand really how this program had an impact, and to also collect some feedback from our participants to see how we can improve our program. About over 90% of our participants said they were overall satisfied with the program. They liked the pace of the exercise, and about 90% said, the instructor was able to modify the exercises and were able to explain the exercises, appropriately. And, as indicated on the slide, about, almost all 98% said they would recommend the program to a family or friends. So again, these were really good reviews. So another thing that we did, we collected qualitative reviews, again, just to collect anecdotal statements to understand really what this program means to, participants. And I'm not going to read everything on the slide, but I'm really going to highlight one specific one that jumped out to me was really the participant that said, I have acquired many valuable exercises from this terrific program, which I now incorporate into my daily routine. Again, this tells us that, this program is definitely having a great impact and also helping participants improve their lifestyle. So with all these great results, we still had some limitations that I just want to share with you. One major thing was really small sample size, which was difficult for us to highlight more statistically significant findings. Also, survey fatigue. This was one of the complaints that we heard, oh, are we going to fill this out again? So I guess participants weren't too eager to fill out the surveys. So one thing we tried to reduce that was we tried to incentivize participants that actually complete both pre and post surveys. One thing again to note, limitation was really this was self-reported data again, which is based on participant subjectivity, and this would influence participants in reporting sociable, desirable responses. And one last limitation that I wanted to highlight was some of these participants, are participating in other exercise programs outside the study. So again, that could definitely have an impact on some of the outcomes that I just shared with you. So in summary, what are we saying about our program? Really, HSS program, is effective in improving musculoskeletal health outcomes and are associated with positive changes in pain, balance, fatigue, fitness, and certain aspects of quality of life. Also, it is really important to identify effective programs that raise awareness and reduce the impact of musculoskeletal conditions. So with this, we still have some next steps. We still have some work to do. And really, one thing is really to implement necessary changes to our program outcome measures and evaluation methodology based on these results. And then another next step for us is really to see how we can increase program reach by providing a variety of, our classes offered. And, lastly is really, so what is the next stage? That's a question for me, is really, what is the next phase of evaluation? We've done this, but where are we taking this? With that said, that was the end of our program, and I'm going to hand it over to Kristen.
Thank you both. I think that was very interesting, and I didn't appreciate until Sandy said it in the beginning that the participants were from the community as well as patients, that they did not have to be patients of HSS. So that's kind of nice reach. Before we get into the question and answer session, I just wanted to remind people that you can either type in a question or you may press the button to raise your hand. Either way, I will get around to you. And I see one question's come in so far, which is about how many of these participants would you say, let me get the whole question, I'm a little bit cut off here. Here we go. About how many of these participants would you say were involved in other activities outside this program? You referenced this TT at the end. And what outside activities would you say they were involved in? Gym membership, physical therapy, that sort of thing?
Yeah, so we really didn't capture that. I just like some of them would mention that in like some of the comments, but that wasn't really one of our indicators that we had captured. But for instance, like gym membership, and then our program, our hospital has this walk-in program that some some would engage in. So these are some of the exercise activities that they could have been engaged in. But we picked this up from some of the one-on-one comments or anecdotal statements that we had collected that they were already physically active.
And it's a very real possibility that they would be involved in physical therapy, either here or somewhere else.
Mm-hmm. That brings up a question that I had actually about the parameter of exercising one time per week in your program. And you certainly saw some nice results with quality of life improvements and symptom improvements. And of course, now knowing that some of the patients were involved in other programs, did you have any thoughts initially about exercising just one time a week in terms of what outcomes you expected, or in terms of thinking about people developing a habit once they've gone beyond this program?
Yeah, I mean, I think it's a great question, and I got to be honest, I was a little surprised just by some of these results because we are only offering the program one time a week, and the reason for that is just logistics, and we offer it here at the hospital in our conference room space, and as you can imagine, everyone's fighting for space. We would love to be able to offer this more times a week, and I think in the future we're going to have to really take a look at that. We actually just submitted an RWJ grant. If we get some funding for that, we're going to be looking at, in one of our programs, whether or not one time a week or 2 times a week there's a difference in outcomes.
Right.
But we're really pleased to see that we can get some of these results with having participants exercise one time a week. Having said that, some participants take more than one class. So they are getting it more than once a week.
Thank you. So I have one person with a raised hand. Let me unmute Melissa. Okay, Melissa, are you there?
Yes, I didn't have a question.
Okay. I wondered, it showed up early. I saw your hand raised. So if you don't have a question,
sorry, I didn't mean to hit that. I didn't think I did. Sorry.
That's no problem. Thanks for joining. Okay, so I do have another two more questions that were typed in that are actually pretty similar. I'll read them both because I do think they're quite related. Well, the first one is, did HSS design their own program, or did you use something such as the Marshall Steele program? Related to that, we had a question, were the programs evidence-based programs for people with arthritis, or basically programs that would be offered in gyms?
Well, we're not necessarily offering what I would call quote-unquote evidence-based programs for this research. We do have other research on programs that we have. We do use the Arthritis Foundation exercise program and such. But for this program, we vetted our instructors to ensure that they had experience with older adults specifically, and with those that have musculoskeletal disorders. So our classes very much are geared to people that have knee pain or shoulder pain, and that really is from the instructor. And so no, it's not technically evidence-based, but we really feel confident in the instructors that we have selected to run our classes.
And then I'm also going to add to what Sandy said. Also, based on research, these exercise programs have been shown to help to reduce pain or improve quality of life or, physical function.
Okay. One other question that I had is very detail-oriented. You showed that exercise intensity levels increased. How did you measure that? Was that a kind of...
No, go ahead.
Oh, I was just going to say, was it a questionnaire, or did you have some sort of physiologic measure, or what?
So it was really self-reported data. So it was really a questionnaire where we had used, a validated instrument that's already available, which is the three-question physical assessment, instrument, and it was really self-reported data. So it wasn't really, another form of measurement where we, collected. It was all based on the questionnaire.
Mm-hmm. Great. Well, so far I don't see any other hands raised or questions coming in. Certainly anybody can ask one in the last minute or so that we have. In the meantime, I just wanted to thank you again, and thanking everybody who participated in the Lunch and Learn today. And as I see no more questions coming in, I just wanted to let everybody know about the November 19th Lunch and Learn as our next one. Will feature Laura Payne from the National Recreation and Parks Association. But in the meantime, thank you, TT and Sandy. That was very interesting, and I think it gives us a good perspective on what a hospital program can do for its patients and the community. So I appreciate it. Thank you.
Thank you.
Thank you.
So I think that's it for our webinar today. Thanks, everyone, and we'll tune in next month. Bye-bye.